Good afternoon, everyone. I'm Christy Koenig, the EMS Medical Director for the County of San Diego. Thank you so much for joining us for the next lecture in our series of evidence-based medicine presentations. Today's topic is pediatric out-of-hospital cardiac arrest. Let's talk about the littles. And we welcome our very own Dr. Joel D'Onofrio, a nationally recognized expert in EMS for children. Dr. D'Onofrio is Associate Professor of Pediatrics and Emergency Medicine at UCSD, as well as EMS Medical Director for Rady Children's Hospital and Deputy Chief Medical Officer for San Diego Fire Rescue. After training in pediatrics at LA County USC, she completed not one, but two fellowships, one in Peds Emergency Medicine at Harbor UCLA, and another in EMS at UCSD. She is triple boarded in pediatrics, emergency medicine, and EMS, and a fellow of the Academy of Emergency Medical Services, or FAEMS, an honor bestowed on only about 535 qualified experts worldwide. We appreciate Dr. D'Onofrio sharing her expertise with us today and look forward to her EBM talk about the latest evidence for pre-hospital resuscitation of children in cardiac arrest. Let's go learn how to save some kids. Over to you, Joelle.
Wonderful. Thank you so much for that. Excellent. All right. Hold on 1 second. You guys see my slides? All right. So pediatric cardiac arrest. Let's talk about the littles. I just love that title. I just want to give you guys a caveat. We are not talking about NRP. This isn't that freshly born liquid-based creature that's getting converted to an air-based environment and learning how to breathe. We're talking about air-breathing pediatric cardiac arrest patients. I do have some conflicts of interest to disclose. I am a member of the American Heart Association's Emergency Cardiovascular Care's System of Care and their Pediatric Emphasis Group. And I co-chair the new American Academy of Pediatrics Neonatal Education for pre-hospital providers. I'm also a PCR doctor at the only tertiary care center in a county. So these kids come to me, and the better EMS care we can give, the better our outcomes. Also the fire department. And I'm not gonna lie, there's a delay. There we go. All of my kids live in San Diego County and San Diego City. So by improving our care of kids with cardiac arrest, should my kids ever have an emergency, you guys are the ones who's going to respond to them. So it's a big deal. Standardized outline. We're going to talk about epidemiology, bystanders, on-scene care, transport, and termination of resuscitation. Now, we're talking about the littles. Little people, little numbers, little data. You always need to question the data and watch it over time. So raise your hand here, because we actually do have shockingly people in the room. Raise your hand if you remember ROC room, right? Big deal, right? So even in a ROC registry with over 22 million citizens throughout the US and Canada, while they have 55,000 out-of-hospital cardiac arrests, 32,000 with epi, look at this pediatric population, less than 1,000 were children. It's really hard to study this to get an effect size sample large enough. We're really talking about little numbers. And to make it trickier, children are heterogeneous, and all the age groups are critically different. As they get older, the subgroups become more aligned with adults. You have increased public places of arrest and shock rhythms. So looking at the etiologies, overall, the top cause, my head is in the way of the screws over there. I'll go there. No, it's me, it's not you.
Nobody takes us out of the shadow.
I can't move my head that way. So the overall cause is hypoxia. You can see, looking through here, you have some infant death syndrome, followed by we have hypoxias, drowning, and then traumas. It really changes based on the age cohort. but the hypoxia is common. Now, if you look at this, you're going to notice that a lot of these things are things that we work on as a community to prevent. For SUIDs, we say sleep on your back, keep the crib empty. We do drowning prevention. We do car seats, helmet, window seat. Because overall, the best death is a prevented death. When we look at ROSC and survival, using the best out-of-hospital cardiac arrest data we have, ROC Cares and ESO actually releases their data, and it's really helpful. We find survival to be low, but overall better than adults combined. ROSC and survival are the lowest in infants, and then ROSC and survival peak in teens. So, dang, it's good to be a teenager. But we really need more ROC style research back. It's just really hard to get the numbers. We're not making strides in the younger populations. So let's break it down. The key is to have everything in place before you need it. You need to be prepared for kids. The National Pediatric Readiness Program has been found in emergency departments to significantly decrease the morbidity and mortality of critically ill and injured children. And as of 2024, we brought this to the pre-hospital arena. We're expecting our national results anytime now. So if you don't have it, get yourself a pediatric emergency care coordinator, basically someone who looks at your system from a peds perspective. Know your dosing and equipment, work on the education, your CQIs. These are all the things that we're doing with EMS for children. So we're going to step it through as if it's from the time of the 911 call. So what happens to the patient before EMS arrives? It truly impacts care. Kids are just like adults. They have better outcomes, but the better outcomes are associated with arrest in public recreational areas, with bystander CPR, and they should definitely get an AED applied. We have to work as a community on this, and we have been. We have the bystander CPR committee, the Revive and Survive initiative to train 1 million people. We're up to 500,000 trained now, and even more. So all this numbers data is 5 studies, 14,000 participants. And these are children who received conventional CPR, and they found they had higher 30-day neuro-intact survival. So for adult cardiac arrest, like the Revive and Survive, like Brad, if I ask you this, are we teaching to give breaths? Are we saying hands-only CPR?
We're saying hands-only CPR for now, but we may be adding breaths to narcotic.
So bystander hands-only CPR, hot, hitting, easier to teach. Is that what we're doing at our 911 dispatch centers? For adults it is, but how about for kids? Should we be doing that with our pediatric population? No. Bystander CPR with ventilations has a higher 30-day survival and neuro-intact 30-day survival, especially in the 1 to 7-year-old group and the non-cardiac etiology, which is the majority, right? I showed you the data. Hypoxia is the #1 cause of cardiac arrest. We need to ventilate. So overall, hypoxia, leading presumed cause of cardiac arrest, with trauma and drowning accounting for a high proportion in kids over 1. This is a 2007 to 2021 German out-of-hospital cardiac registry. And they found bystander witness out-of-hospital cardiac arrest and bystander CPR rates were the highest in kids 1 to 4, which was like 43.9 and 62.3 respectively. So this is really interesting. They looked and they said, well, what happens if you're doing conventional versus hands only versus with the breath, or conventional versus continuous CPR with bystanders versus EMS? And what they found is that bystanders doing conventional CPR with rescue breaths had increased ROSC and increased neuro-intact survival. It's a really big deal. When they looked at the compressions of doing continuous versus conventional, like the 15-2 versus every once in a while, it didn't change with EMS. So you have the breath. So for peds AED, there's really very small data on peds AEDs. But we know that even in a pediatric population, a shockable rhythm has a higher odds of ROS, survival and neuroattack survival. You can use an AED in all ages, and it's also a very calm presence. It walks the bystander through compressions and rescue breaths. In San Diego, we have Project Heartbeat. I think you guys all know that. So we're the medical directors of Project Heartbeat. We had 3 cases over the past few years where the AED rhythm strip being brought to the Children's Hospital made a definitive change in the patient's diagnosis and treatment. So we should be supporting AED public access, the use in children, and if possible, help find a way for that rhythm strip to actually make it to the emergency department. No, that wasn't syncope. The patient truly was in torsades. The AED did defibrillate and the patient got pulses back. That ocean drowning with oral trauma where the lifeguards placed AED and defibrillated, that wasn't a trauma activation. That kid was actually in torsades and got defibrillated. We've had channelopathies, congenital structural heart defects. Shockable cases need proper workup, and sometimes we're not seeing that except during the AED, so we've got to get that rhythm. All right, so now we're on scene. So if the patient's lucky, they got a witnessed arrest with bystander compressions, ventilations, they had an AED applied, but oftentimes they don't. So let's talk about the EMS aspects of pediatric cardiac arrest. It's all about the basics: compression, ventilation, defibrillation, getting access, and epi onboard stat. The team needs to be mentally prepared en route. Who's on compression? Who's on ventilation? What are we using for access? What's the dose for defib and epi? And yes, the PDCs have ages on them, so you can mentally prepare en route to the call. Be ready to hit the ground running. You can plan all of this ahead of time as soon as you know the age. And there's plenty of ways to have a weight based on the age and dosing pre-calculated, so you don't have to do this, but we already have the PDC, so you don't have to worry. So remember, if you do this for all of the potentially bad 911 calls, and they end up not being cardiac arrest, you mentally strengthen and practice, so you're going to be even better prepared for the next pediatric cardiac arrest. So we really have to prepare. Continuous versus conventional CPR may be controversial, but focusing on high quality compressions really is not. This is very similar to adults. You have to have high quality compressions. Your hands are their heart. If you stop compressing, their heart stops beating. Those are the words of one of my favorite teachers. This is Dr. Helen Harvey from Rady. She's one of our intensivists. Mechanical CPR devices do work on children as long as they're big enough for the thumper to get all the way down. So early recognition and initiation, push hard and fast 100 to 120. You want 1/3 the chest diameter, allow for recoil, don't lean on the chest, have a hard surface under the patient, limit your interruptions, avoid hyperventilation. You want to put the end tidal on before you leave the scene so you can actually see what it is. And you have a goal of over 20. So our goal for chest compression fraction is to have over 80% of the code we're pressing on the chest. At Radies, we actually started tracking this. So we have a code blue committee in every single cardiac arrest at Children's over the past, I think it's been 2 or 3 years now. We actually go back and we're judgy. We look at how is your compression fractions, how is your ventilations, what did you do? And we actually are looking at all of our cardiac arrest data. We really want to minimize time off chest and ensure a good recoil. I need to put a little caveat in here. When you pause, you need to make sure to pause long enough to actually see what the monitor is showing. It's oftentimes that we're so fast to feel a pulse that we forget to actually do a rhythm interpretation to see, is it asystole, is it PEA, is it something shockable? And that's something that we find both EMS and in hospitals. So we want hands on chest, but you also want a long enough pause to figure out what's going on under there. There's a lot of tools to assist with giving correct compression depth, rate, evaluating the underlying rhythm. In addition to the technology, your medic lead in the resuscitation or someone in your team in the ER should be checking the compressor's work. This is where you want someone who's super judgy. In the ER, we have a CPR coach. They literally, their whole job is they watch whoever's giving CPR you're too fast, you're too deep, you're not allowing enough recoil, and they literally, that is their whole job, is they're judging the CPR quality, because that is the most important thing. And many of the defibrillators have metrics. You want your end tidal CO2, you want your pulse ox. If you have a puck on there, you can get your depth and your rate. But I'm gonna pause for a second, and I want you to think. Can the equipment that you have right now, whether it be on your rigs or in your ER, can it monitor your young children? Can you capture compression fraction on a 2-year-old? I don't think everyone can say yes to that one. So while you're starting the compression, remember the pads. While it's not super common, kids do have shock rhythms. We have renal problems that lead to hyperkalemia. There's genetic states that can predispose to tachydysrhythmias. And we all know this, right? I'm preaching to the choir. You want to identify and treat the shock rhythm as soon as possible. These are the kids that give us the fantastic outcomes. You want to defibrillate on the rhythm check. And the interesting thing though is when they looked at it for kids, the 2-minute time difference between shock immediately or do 2 minutes of CPR and then shock, it didn't have a difference in the pediatric population. So whatever you're doing with adults, keep it the same so then you have one less thing for people to remember. So hypoxia is the #1 cause of pediatric cardiac arrest. I'm just gonna say that over and over and over. You want to have your BDM ready. You want to make sure it fits correctly. It has a good seal. When you actually inflate it, you have chest rise. You want a end tidal CO2 placed. You need to have a pulse ox placed. You can track oxygen and perfusion using a pulse oximetry. And I think all the ear docs in here, we would never have a cardiac arrest case where we're not putting all of those on. So in EMS, we need to really start adding the pulse oxes on. Ventilation's a skill. It requires constant steady focus and feedback with adjustments as needed. It's just like compressions. We really have to be judgy with how we're ventilating. As for the correct rate, I know there's a lot of controversy about this. Should we do the conventional 15 to 2? Should we do the 1 breath every 10 seconds on the upstroke? You know, my review, it shows that we get distracted. We have gaps, we have apnea, we have hyperventilation. Usually people are so freaked out with a pediatric case, we're not ventilating appropriately. And then we forget, oh yeah, we're supposed to ventilate, bag, 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 bag. And then you stop. So whatever it is that you're using, look at it and actually CQI yourself and make sure that you truly are ventilating appropriately. So what about airways? Advanced airways aren't actually associated with survival and ventricular intubation or supraglottic airways. There may be some ease on crews with advanced airways, especially in the longer transports. Like there might be a few other things that are perks besides survival, but really survival favors the DVM. And this matters because you have to have good VDM, regardless of if you have an advanced airway in your scope of practice or not. Good VDM matters, and you should train on this. Pre-hospital supraglottic data, it's really that ever popular iGel. The literature is not great so far. It shows higher first pass success for adults and peds. But right now, the literature we have for supraglottics in the out-of-hospital arena are when they were used as a rescue device. Like basically, I traumatized this airway with a tube, and now I'm slipping in a rescue device, and that's not fair to the supraglottic. I think we're going to have more data coming out. Many agencies are moving to this. I'm not opposed to using it, but if you're going, I need to have hardcore literature, it's not out quite yet. In late 2023, the National Association of State EMS officials, NASEMSO, came out with model clinical guidelines for pre-hospital airway management. Of note, I was one of the 3 pediatric experts on this committee, and we came up with a consensus on pediatric airway management based on literature and expert physician, educator, and medic's opinion. And this was actually written by the infamous physician, Dr. Jeff Jarvis. So I'm going to read it because I think he put it together really eloquently. Pediatric patients are a heterogeneous group, and airway management strategies must optimize ventilation and oxygenation while minimizing complications. BDM is the starting point of ventilation and may progress to supraglottic airway. However, progression to endotracheal intubation should be done rarely in the face of lower endotracheal intubation success rates, higher complication rates, and lower patient volumes, leading to decreased experience in this population. All decisions should be guided by the clinical status of the patient based on ongoing assessment, monitoring, etiology, and expected clinical course. So we also need to have a high-quality randomized control trial, right? And it's underway. So Doctors Henry Wayne, Mary, and Gaushi Hill got together and they were approved NIH funds to conduct a study. It's a randomized control trial right now. They're doing DVM versus supraglottic airways. It started in May of 2024, and we're expecting those results to come out in maybe 2027. Then they'll take the winner of that to compare to endotracheal intubation, and we're expecting the results to come out around 2030. And there's 10 large EMS systems participating in this. So compressions, ventilations, and access. Someone needs to be ready to drill. IO, IV access and fluids are associated with increased survival in the ROC studies. So in regards to IO, what's the optimal location? This is a hot topic. Proximal tibia is the classic location, but it has a really high failure rate. So don't be afraid to have a spare ready and to check for extravasation. The distal femur is looking really to be optimal, and some EMS agencies have moved to this. And in our ER radius, we definitely use the distal femur. The proximal humerus is seen as a little bit controversial in the very young. There's a small torso, it's next to a shoulder, there's a lot of movement with compressions, and there's a question of growth plates, but they do work and they work beautifully. I have placed proximal humerus IOs on small children. Our local children's hospital orthopedists have even opined on this, and none of these three sites is a danger to place in their orthopedic opinions. But it's good to have options. So remember, IO is a policy. What can you place? And then you have to have education, hands-on training. So if in San Diego we add a distal femur IO site, you have to remember to get your trainers for that. And then also, a lot of cardiac arrest in kids are in the infants. Get eggs, train on eggs. Have your medics actually drilling eggs into get that feeling of you're not going to push super hard. You just kind of want to lightly break through the bone to get practice. So everyone loves to give epi a hard time. It's a messy drug, it has a complicated history, but what's not controversial is to give it in pediatrics, all ages. And it needs to be given quickly because delayed epinephrine is associated with worse outcomes. Pediatric in-hospital cardiac arrests have shown get it on board within 5 minutes. After that, the timing of subsequent dosing, the overall number of dosing, we need more data. The longer delay between doses has been found to be favorable, but that's really, we have to kind of see with time and data kind of what's coming in. So you might be thinking 5 minutes, what? Well, ROC, they showed time to first dose epi was 6 to 12 minutes for an IQR. So pit crew training, my friend, pit crew training, you guys can get epi on within 5 minutes. So just to reemphasize this 2011 to 2015 ROC data shows majority of patients receive epi after 10 minutes, and each minute delay in epinephrine was associated with decreased survival and unfavorable neuro outcomes. This is a study I did with Remley Crow using 2019 ESO data. We had over 800 patients with pediatric cardiac arrest, and we presented this at DESEMSO. We're working on a publication. So it's not actually out hot in the press yet. But we showed the younger the patient, the less likely epinephrine was given. Half of our neonates, and this group was all over 1 year of age, so this is an NRP. Half of our neonates did not get epinephrine. And the younger the patient, when they did get epinephrine, it was more likely to be given in transports. So our pediatric patients had more transports, shorter ski times, and less ROSC than our adults with non-shockable arrest. We compared to like non-shockable adults, showing that kids get, just as we would expect, scoop and run. So you can see with this graph, survival to discharge falls as time to epinephrine increases. In order to get your compressions going, adequately initiate the critical ventilation, and get your epinephrine on within 5 minutes. You have to initiate resuscitation where the patient is. You need to be strategizing what you're going to do when you're going to the call. You have to have a prepared pit crew and on-scene resuscitation. Now, how about those shock kids? Lido, Amio. Well, there's no statistically significant differences in ROSC, survival to 24 hours, survival to hospital discharge, or favorable neuro outcome between Amio or lidocaine for shock refractory VFib and pulseless VTAC. Apologies. Very dry. These findings support the current PEDS cardiac arrest guidelines, but the results were small in number. Again, just a little data. So we spoke to our own pediatric cardiologists about our pre-hospital protocols. And they actually favored lidocaine over amio because it has less messy side effects. That was why. So we changed our protocol to say lido's preferred over amio, but both are allowed to be given. Both work, and medication shortages are real. So I think I'm saying this over and over again because it matters. Your EMS crews need to prepare and route to the call. Then apply CPR care on scene. Compression, ventilation, rhythm check with pads in place, access and epi within 5 minutes. What happens if you apply this as a bundle? So Banerjee's group applied this as a bundle of care. They initiated ALS care on scene. They did tightly controlled ventilatory rates. They had immediate IO placement. They did early age-based epidosing. Like they determined it and actually pulled it up while en route to the call. They used the pit crew approach, and I love this. They stressed having a dedicated person for the family to explain what was happening, how they were doing everything to try and save their child's life. This has a huge impact for the families and the crews. I think we all know how anguishing the wail of a distressed parent can be. And they found they were able to increase their ROSC and their neurointact survivors. Look at this. Isn't that crazy? They went from 2 ROSC, no survivors, to 13 neurointact survivalists and 17 ROSC. That's ridiculous. And what they found is their time to epi went from 16 minutes to 7 minutes during the study. So we went, oh, this is so cool. We want to do this. So we're actually in the midst of a pediatric out-of-hospital cardiac arrest CQI initiated because of that paper. And I have to give a special thank you to our SDFD team, especially Joe Russo, Esther Garcia, and Jeff Kleins. Like, you guys have really supported this project for a number of years, because you can see we started this in October 2019. We trained 600 paramedics and bridge EMTs. We started at the time of the 911 call with the mental prep. Like, they had to start in the room, they were going to get called, and they'd have to think about things while they were heading to the scene. We implemented our QI measures, stressing stay on scene, pit crew CPR, quality compression, ventilation, early access, early epi, family support. We used our own case scenarios. This was our pool drowning. We included the transition when the ambulance arrives on scene and joins fire, the transition into the ambulance, going through in the ambulance trying to do CPR. We had base hospital communication. We did ED handoff simulated. We did this all throughout October 2019. We repeated it in 2020. We also modified our own pediatric drug charts at that point to include age. And when we looked at our data, we were not staying on scene for resuscitation. Why? Can you guys think about why we would not stay on scene? If you heard this lecture, you're like, no, I already know, you told me like 5 times. Why didn't they stay on scene to resuscitate? They're having a seizure.
They're freaked out.
They're messy. They want to do something. Any other reasons? The picture is a hint.
Parents.
Yeah.
they just hand you them and you have to just go. They don't, yeah, it's not like an adult. They usually run out to the thing, they hand them to you, and then you get in and go. And so it's a medicine in motion. And I think as a provider, you feel that the hospital has definitive care where you are just a mode of transport.
And that includes PD running, packaging, and CTR.
Yes, that is exactly 100%. The kid is carried out. And we asked this of a medic. We had this medic, we were like, what happened? Like, we've done this, we reminded this in CE like 3 times, and they went, well, the kid was carried to us, thrown in the ambulance. The captain slams the back of the doors of the ambulance and then goes, go. How do you stay on scene when someone's slamming the back of your ambulance saying, go, go, go?
Captain turning TV on.
So that's legit, right? Like that's a real one. And this is what continuous process improvement is you have to look at things and then find out where you have gaps. So we added, and we were, okay, we need to change it because we've only been teaching the paramedics and the EMTs who drive the ambulances. So now we actually need to put this through all SDFD responders. Everyone who responds needs to be on board. And I still remember, it gives me goosebumps every time. We did this, it went through our BMO training, and then I got a text message after BMO stopped, like right after it finished. And one of our medics went, Dr. D'Onofrio, it happened. I arrived to a pediatric cardiac arrest. I walked up and the captain went, we are not loading and going. We are staying on scene. We're doing pit crew CPR. And he's like, we stayed. Like it still to this day gives me goosebumps. Like that's what it takes is you have to have everyone on board. We had a subjective increase in ROS. In 2021, we updated our pre-hospital protocols a little bit. We updated the CPR to be similar to adults. We added in push dose epi. And then in January 2025, we actually implemented a San Diego County QI project to focus on compressions, defibrillation, oxygenation, ventilation, and epi. So our city data, this was 2014 to 2022, or it was like, sorry. Yeah, it was a handful of years, kind of like looking stepwise as we were doing our projects. It's low numbers. So in the city, we only had 126 pediatric cardiac arrests over 9 years. We had 11 survivors in 9 years. 9, aka 80%, were in the last 4 years. So most of our survivors were in the last 4 years of us doing this QI project. We average only 14 arrests per year. But in this project with doing this, we trended an increase in ROSC, an increase in defibrillation, which I don't think was caused from us. Survival to admission was increasing until COVID. And the patients we did get ROSC on had survival to admission. But these are, you might be thinking about this, like I'm a big fan of population health, right? These are low numbers. It's a lot of work on us, right? It's a lot of training, it's a lot of QI. But I would say, well, while these are very low numbers, these are the big emotional impact cases. These have big system impacts. These are cases that are going to burn people out that they remember forever. Oddly, we did find 3 patients who didn't have ROSC who survived to discharge to a good CPC. So kind of, I think we need to have more data on pediatric cardiac arrest. Now, in terms of our county-wide QI project, Dr. Vitellani put up our aims. So we looked at that at our last EMSC advisory committee earlier this month. So we have January to June data. So we have only one time period. We have 15 cases. Our median is 2 years, but they range from 1 month to 17 years. Majority were female and asystole. We had 87% asystole, 13% PEA. For our aim 1 about compression rate, we want to have a compression fraction over 80%. And of the 15 patients, only 5 of them actually measured compression rates. So remember I was talking about, do your agencies actually measure these things? A lot of agencies aren't capturing that data because you have to get the pediatric pup. So that's something we should probably be looking at. 80% received epinephrine on scene. We want to get that number to over 90%. And aim 3 was that we have ventilations initiated on scene. I actually changed it, and I haven't told the group yet, to are we placing an end title on scene? And we have 87% placed an end title, period. And 70% of those were on scene. So I think we need to, these are movable metrics. We need to monitor chest compression fraction. We need to get epi on scene, and we need to get end tidal CO2 on scene. In terms of our outcomes, we're not going to get those until May of 2026. And as I showed you, we have such a small N. I don't think our outcomes are going to be hugely changed, because all you have to have is 2 patients to change something. And pulse ox was only placed in 2/3, so that might be one of our other aims. We might add another aim to increase pulse ox placed on patient. This isn't ad state, this is just overall. Anytime during the call they place a pulse ox, only 2/3 of the cases. We are going to do an EDQI component as well. Most of the hospitals have said they are interested in doing this, so stay tuned. Everyone should be doing high quality CPR care. So we talked about the pre-EMS arrival, EMS, now transport. Who do you transport? What do you transport? Do you transport? It's really tricky. Can you even apply termination of resuscitation to a pediatric patient? So raw data showed increased survival in the 10 to 30 minute window. So don't scoop and run, but don't stay on scene forever. But this data is really messy. They have, is it longer scene times because there are more fetal cases? Do you have shorter scene times but there's no access or medications? It's kind of iffy. So where you should transfer really depends on where you're located. PEDS equipment is size dependent. So the thing is that you really need to let the ER know ASAP, like whatever hospital you're going to, you need to let them know as soon as possible so they can assemble the correct teams and have the correct equipment and meds pulled. They need an age, or even like it's a neonate or a toddler, like some approximation, because I can tell you the meds we pull up for a toddler are not the same we're going to pull up for a neonate or like a teen, or a length-based resuscitation color, but give us something to start preparing for. And when you get there, you're going from one hit routine to another. So when you arrive, you want to have a careful transition of care, minimize time off chest, continue ventilation, watch the access lines, and if you have an advanced airway, you have to treat it carefully. All patient transfers are a high-risk time. Now, everyone, including me, loves to talk about ECMO, or better called ECPO. So did you know that ECMO was actually created for congenital heart patients? Pediatrics are the originators of ECMO, and we've been doing it for decades. So pediatrics should be discussed as the systems of care, and we should make sure that everyone has a seat at the table when optimizing the sphere systems for pre-hospital ED and the CDICU. So bring it.
Yeah.
So let's talk about TOR. Can you do it on kids? Yes. Should you do it on kids? Complicated. We have classic field determination for adults. You guys know this. So Dr. Kathy Stats had an interesting case that brought this to light. There's a lot of controversy, and if you're not in EMS, people don't know EMS. They don't know are you even allowed to pronounce a child dead? Like if you're a base hospital doctor who doesn't know EMS and you're getting that call, are you allowed to pronounce a child on scene? So she looks at all the LEMSAs to see what's going on. And stay and resuscitate weren't often mentored, but 30% did support and 15% did not. TOR was allowed in 67%. 12% required transporting of all pediatric cardiac arrest, and 20% just don't mention it. Now, Maryland has a statewide termination of resuscitation. So if you're asystolic, you get 3 rounds of epi, your end tidal is less than 15 minutes, and you've spent 30 minutes or more on scene, you are allowed to terminate in Maryland. And some of the most notorious PEDS EMS specialists in the county, Jen Anders, Kathleen Allagace, Matt Harris, upcoming star Jen Fish, they took this and they worked with Remley Crow from ESO and used ESO's data to apply the Maryland TOR to a pediatric population from ESO and found it has really high specificity and low sensitivity, AKA it works really well. So if you're asystolic, greater than 3 doses of epi, end tidal less than 15, seat time more than 30 minutes, there was no survivors except one drowning patient. So they say the tour works, just don't do it for drowning patients. So these are really low numbers we're looking at though, and each system is so regionally different. And each pediatric case is highly different and emotionally packed. There's different scenarios, different rescuers, different scene safety factors, and these are going to impact your crews and your teams heavily. So when they come to me and they go, so are we supposed to stay and terminate? Are we supposed to load and go for everyone? My own words are stay on scene to get compressions, ventilation, shock as needed, get your epi on board. And then after that first dose of epi, that's when you start to consider, is this a case that you're going to work on scene or are you going to transport? And where the destination hospital should be, that's really regionally dependent and has a lot higher level of discussions. But all emergency departments should be pediatric ready for any kid who's coming in. So in summary, treat kids like adults. Public health measures matter. Bystander CPR, AED. Be prepared as a system and as a team. Pit crew CPR needs to be initiated on scene. You should be preparing for it en route. And when you get there, it should be compressions, ventilation, shock, epi, stat. Don't consider transport until after that first dose of epi. Let that receiving hospital know as soon as possible, especially if the agent size, so they can start getting the correct stuff ready. Optimize your ED handoff and tour. It is possible, but also there's a lot of messy caveats. So thank you. If you enjoyed this talk, feel free to go to Joe Finney and I have a podcast, the Pediatric EMS podcast, and it's free. You can get Medic CE, and we have a ton of really fun educational podcasts. And our EMSC has an innovation and improvement center that has a lot of education you can get as well. So free resources are always appreciated. Thank you.
Thank you for that wonderful lecture, and what a fabulous illustration of a quality improvement initiative with measure, improve, measure, improve. I see Dr. Schwartz has a hand up.
Oh, how'd you know it was me this time?
That's not Dr. Schwartz.
A quick learner.
Yeah, that was a great talk. Thank you. Do they recommend only AP placement for kids? Or
Generally, yeah, it's the go-to. It's not steady though. There's not a lot of data.
right. So I was wondering. The other was that the ventilations, not they make a big deal about over ventilating, not necessarily the rate, although that can contribute, but the volume. And so what do you recommend teaching with regards to the volume besides just rise and fall of the chest?
Oh, it really should be rise, but you should also, you're opening like a can of worms. So who do we have bagging these patients?
Yeah.
The EMTs, right? The new EMTs, they're not like, I think if you're in the ER and you have a patient who needs to get bagged, who are we having bag the patients in the ER? A respiratory therapist or one of the doctors, right? You always have like the most dedicated, skilled person at the head of the bed because ventilating is such a hard skill.
Right.
I would say I wouldn't try to make it super complicated. I would be like, to make sure your 100% focus is the mask correctly sealed? When I squeeze it, am I getting enough rise? And on my end tidal, do I actually see, oh, I have a breath. Oh, I have a breath. Because when you look at the codes, and I've been doing this for years, when you look at the pediatric cardiac arrest monitor files, what we're finding is they get distracted and they're not doing the ventilations, they're not getting VVM capture, and it's adult and kids.
Yeah.
And so I think we really just need to overall teach how to do BVM and how to look at your end tidal CO2 monitor with bagging at a higher level.
I've been teaching them about between 5 and 7 cc's per kilogram, and then I'll ask them how many cc's are in the bags. Nobody knows. It's interesting. It's not written on the bag, but if you know how much is in the bag and how many cc's, gives you an idea so that you don't overinflate and decrease.
They're not doing math though. They're freaking out because there's a mom screaming that her child is dying. There's such hard calls to listen to. We have audio on ours. So when we do case reviews, I'm usually listening to the sounds as well. And it's, I don't know if anyone who wants to unmute yourself and talk about your last pediatric code and how were you thinking about doing math during it? As an
You could
EMT.
do it on the way there.
Do it on the way there. Yes, do it on the way
Right?
there. Prep.
I learned something.
But it's all like, man, I think we should have EMTs using end-tidal CO2 to track, are they getting a breath? When they squeeze, are they actually seeing a dolphin? Huge.
And the last thing was, it was interesting that one study showed that the drowning, they don't really want to apply TOR. And it was in Maryland. So I think we always have to consider and remember that hypothermia can be a big component of it. And kids have a huge, very potent diving reflex compared to an adult. So they're like little seals under the water that can survive pretty good.
It's true. Especially important for San Diego because drowning is one of our top causes of death.
Great discussion. It's a very difficult topic, a low frequency event. It's very, very challenging. One of the key questions is there something available at the hospital that's not available on the scene? So there are social challenges, as you pointed out, to staying on scene, but it's important to get that kid stabilized before you get en route. Do you have any comment on pre-arrival dispatcher instructions for children? Do we have any data whether people are more likely to follow the instructions in children than adults? And do we have any data on what other countries are doing with that? I know you mentioned that one German study. I was wondering if they had dispatcher directed CPR. Thanks.
We do dispatch directed CPR for the pediatric patients, and we do it age-based. Like I know our San Diego fire system, we do rescue breaths. If it's under 8, we do ventilate and we teach the bystander how to do the rescue breaths. I don't know if there's any study looking at this, if like the parents' willingness or how effective it is. Like there's truly a gap in literature. So if you're sitting around, you're like, wow, I'm really bored and I want to do some studies, like come at it. We have so I should also say I'm on the pediatric BLS writing group for the AHA, and we've been working on our 2025 guidelines. And so I've been looking at like, this is BLS stuff and looking at the data. There's just not a lot of pediatric data.
The PDS standard is ventilations up through, including through age 8. But it's entirely possible that people don't always deliver those pre-arrival instructions exactly to the MPS standard.
And I don't know if you guys know this, not all dispatch centers have to do CPR. Isn't that weird? Yeah. There's 911 centers out there that don't do CPR.
They don't, what do they do?
Nothing.
I mean, there's 911 centers out there that don't do any NPDS, that don't do any call taking, questioning, interrogation, call stratification. But post call instruction, like pre-arrival instructions.
Yep.
So let's post that so we can tell people not to move there.
The housing is cheap.
I have a question.
I don't see any other questions in the chat, and I don't see any other hands raised. Are there any other questions or comments?
We have a hand up in the room. Ennis.
2 hands up.
You said epi on board immediately, ASAP, yesterday. With the new protocol, postage VTAC and VFib said give the epi after the second shot. Can you explain that?
So if you arrive and you shock, 2-minute CPR shock, you can still have epi on board within 5 minutes. I'd also like to give the caveat of that's gonna be so rare. So rare in pediatrics. They're almost all PEA and asystole. So for the most part for kids, you want to get the epi on. So even if you're defibrillating someone, you can still have someone putting a drill in there. So you can be all ready so that after that second shot, you can give it.
Okay. And you said that ventilation needs to be ventilated really quick. Are you finding,
Oh, by ventilating really quick, I mean, have your BDM ready to apply to start ventilating them? Not ventilate really quick, but more be quick to put the BDM on them at a correct rate.
but are you finding family members doing mouth to mouth?
Yeah. Yeah, but it's interesting, so I have, I see these patients in the ER, right? And we train at dispatch if you're not breathing normally to start CPR. So I have families who come in and they go, oh, I gave CPR or I gave rescue breaths, and I usually go, oh, do the CPR on my arm that you did. And they're like lightly just tapping my arm, and then they go, I did rescue breaths, and I describe what you just did, and they're like, I just go at their mouth. So sometimes the things I think that's why I started asking, so you're like, how much, if you say you're doing chest compressions, how much is it? And it's, sometimes it's not as effective as you would think. So there's actually a lot of studies about that. Like, if you're walking a bystander through a rescue breath, do you tell them to do a head tilt chair lift? Do you not do it? Like, there's all these, what actually works and what can you get a bystander to do?
If you want to look at bystander CPR, I would recommend getting the police officer, because they're typically there first, their body cam footage.
Oh, that's an interesting idea. That'd be a really cool study. Yeah, a lot of hours. Yeah, right.
Part of the challenge with the bystander CPR and the ventilation breaths was by the time the dispatcher was finishing the instructions on the breaths, nothing had happened and the paramedics had arrived. So that's one of the reasons in the original adult cases that we went to the hands-only CPR rather than ventilations for dispatchers.
But I think,
Questions?
to Joelle's point, I just want to reemphasize this. So when we look at our bystander CPR rate and our CARES data, and we're at 51%, probably over half that is dispatch directed. And is that adequate? First of all, we know it's delayed. Second of all, is it little tapping on the arms, you know? So something we have to keep in mind when we look at that data.
Well, thank you very, very much again for that outstanding lecture. We appreciate it. And we're going to go save some kids.